Welcome back. We are going to continue our lesson with the endocrine system and cover those glands that we haven't talked about. So recall that the endocrine system is going to include the thymus, the pancreas, the adrenals, the pineal pituitary, hypothalamus, ovaries, thyroid, parathyroid, and testes. So our last lesson was really focusing on the hypothalamus and the pituitary gland. So now we're going to cover the rest of these glands. So we're going to start by talking about the largest pure endocrine gland, and that's the thyroid. And what we mean by the pure endocrine gland is that it's only going to secrete hormones. There is no other function in another system like the pancreas. That's a very large organ that secretes hormones, but it also has a function in the digestive system. So if we look at the thyroid gland, we can see that it has this distinctive butterfly shape. And it has a right lobe and a left lobe. And what connects the two lobes is this bridge called the isthmus. The thyroid is located at the base of the neck, just underneath the larynx. And it does have a darkish red brown color because it has a really rich blood supply since it's secreting hormones. So the two hormones that the thyroid gland is going to secrete are calcitonin and thyroid hormone. Calcitonin is going to function to reduce the calcium levels in the blood, while thyroid hormones, there are two types. There is T3 and T4. T3 is triiodothyronine, which is why we always just call it T3, because that's a mouthful, and thyroxine, which we commonly refer to as T4. And those hormones are going to work to regulate metabolism and heat production. It's going to control cellular usage of oxygen and maintain blood pressure. So recall that the hypothalamus is going to be a gland that secretes a hormone. And it will secrete a hormone called thyrotropin releasing hormone, or TRH. And that will go to the anterior pituitary. Well, that pituitary gland is going to start secreting thyroid stimulating hormone. And that thyroid stimulating hormone will travel through the blood where it will get to the thyroid gland. The thyroid gland will be stimulated to secrete thyroxine into the blood, and that is going to increase metabolism. And when the thyroxine levels get too high, that's going to be detected by the hypothalamus, and that will trigger the hypothalamus to stop secreting the TRH. So here's an image of the location of the thyroid gland. You can see that it's located in the neck, and on each side of the gland we can see those jugulars, all those blood vessels. So we have the jugulars here, and then you can see the carotid arteries here. And then over on the side you can see a real image of the thyroid. You can see the trachea down below, and then you can see the right lobe of the thyroid and the left lobe of the thyroid, and then that isthmus right there. So if we were to zoom in and look at the thyroid under a microscope, the first thing you're going to probably notice are these circle-ish structures. These are called follicles, and those follicles make up most of the thyroid. So the follicles contain a fluid that's a very protein-rich colloid. So that's what you see here. This is that colloid. And what actually is making up the walls of the follicle is what's known as a follicular cell. And so you can see this simple cuboidal epithelium that surrounds the colloid. And if you look at the nuclei, they're kind of roundish shaped, and you can imagine that cell membrane there in between, and they're kind of squarish. Well, these follicles are actually what secrete the colloid. And the follicle is the structural and functional unit of the thyroid gland. So what lines these follicles are those follicular cells, and those follicular cells will secrete thyroid hormones, the T3 and the T4. And then there are other cells that are next to those follicular cells called parafollicular cells. And you can see they're a little bit larger than the follicular cells, and they are much more spread apart. There's not as many of them. Those are the parafollicular cells that secrete a hormone that's called calcitonin. And those are also called C cells. So talking about the follicular cells that secrete thyroid hormone, if I were to have you take a look at these structures, this is a structure of T3, this is a structure of T4, can you see the difference between those two molecules? You can pause the video if you want to try to find it. But if you look right here, there is an iodine missing. So what the difference is either there are 3 iodine molecules connected or there are 4. And about 80 to 85% of thyroid hormone that's secreted is secreted as T4. And that will travel through the blood and it will go to the tissues, which are the major effector. And in the tissues, that T4 will get converted to T3. And T3 is the more active hormone. So this is how T3 and T4 is made. If you look on the left here, we have a capillary. In the middle here, this is that simple cuboidal follicular cell. And on the right, this is that colloid. All that yellow material is actually a colloid molecule. So if we follow the steps and if we locate the first step here, step A, this cell is going to use the rough endoplasmic reticulum and the Golgi body to do protein synthesis, like what we talked about in the first lecture. And that protein synthesis is to make thyroid globulin. So thyroid globulin is then going to be packaged up and put into a vesicle here. And that vesicle will get transported to the lumen and actively secreted into the lumen or the colloid. And that thyroid globulin is going to be represented in this diagram by this little purple rod. And so if you look in this upper corner here, you can see that this is a section that we're zooming into with the blood vessel and then the simple cuboidal cell, and then this is the colloid that thyroid globulin is being secreted into. So step 1 is the thyroid globulin is synthesized and it is transported to the lumen where it is secreted. Well, at the same time, if we go over here to B, if you look at these molecules here, this is iodide. So at the same time thyroid globulin is being made and secreted, this iodide is being removed from the blood and it is actively being transported throughout the cell and released into this colloid. So in the colloid, this iodide has been oxidized to iodine. If we look at step here, step C. And this is actually going to change the charge of the molecule a little bit. If you recall from chemistry, to oxidize something is to remove an electron, or oil, OIL. Oxidizes, loses an electron. So this iodine will be added to the thyroid globulin that was just made. And of course you're thinking if 3 iodide were added, then you'd have T3, and if 4 iodide were added, there'd be T4. But that's not really the way it actually works. So the way it really works is that there will either be 1 iodide added to make what's called MIT, or mono, and if 2, where's the 2? Right there. These ones, there are 2 iodine molecules added. In that case, it would be di, for 2. And these different combinations of 2 and 1 are what will come together to form the T3 and T4. These 2 thyroid globulin molecules will come together, forming T3 and T4. That is step 4. And then that T3 and T4 will then get put into a vesicle and brought back into the cell. It will get transported through the cell, but as it does, inside of that vesicle, there are what's called enzymes. So it's brought into a specific vesicle called a lysosome. And that lysosome is basically just a bag of enzymes that can cleave or cut T3 and T4 from the thyroid globulin molecule. That way it can be excreted into the bloodstream, which you see here in step G. When we were thinking about thyroid hormone, you need to think about metabolic rate. So when we're talking about metabolic rate, that refers to how fast all of the metabolic reactions happen in your body, how fast it can do metabolism and all of those chemical reactions. So thyroid hormone will increase your metabolic rate. Therefore, it's going to increase the production of ATP and use. So it's going to use a lot more oxygen. And ATP production typically, and chemical reactions usually generate heat, and that's thermogenesis. Thyroid hormone's also going to speed up reactions that are done on a daily basis, like the utilization of glucose for ATP production, and lipolysis, which is the breakdown of fats. So when thyroid hormone is released, because we're going to have increased ATP production, that means we're going to increase our oxygen consumption, since oxygen is an input of cellular respiration. And with all of those chemical reactions speeding up, we need more oxygen for those chemical reactions. And all of those chemical reactions producing all that heat is called the chalogenic effect. So everything is going to increase. Our respiratory rate, heart rate, strength. We're going to have a more ferocious appetite. So there's going to be an increase in growth hormone secretion, and we're going to have a higher level of alertness and reflex speed. So what's going to stimulate the thyroid hormone to be released is things like, well, if you don't have enough of the hormone, well, that will be detected by the hypothalamus, and the hypothalamus will tell the pituitary gland to, hey, release that thyroid stimulating hormone. So the thyroid will then be stimulated to release more hormone to get the levels back up to normal. We can also have stress. Stress will increase how much thyroid hormone is released. Cold will also increase how much thyroid hormone is released because thyroid hormone will help warm you up because it increases that metabolic activity. Pregnancy has lots of increased metabolic needs, so thyroid hormone will be increased. Some thyroid gland disorders include creatinism, and that is a neonatal form of hypothyroidism. So hypo means that there is not enough thyroid hormone produced, and neonatal means that they are either born with or it develops right after birth. So the cause of this is an iodine deficiency during pregnancy, or sometimes there's a genetic disorder of the thyroid hormone being able to be produced. So in the United States, this is pretty rare because we have iodized salt. And this is tested for also when a baby's first born. It's part of that little heel prick that a newborn baby gets. And if they are identified as not having T3 or T4, well, they can just be treated with the hormone. If there isn't any treatment, it's going to result in dwarfism with mental retardation. And so there's some pictures of some brothers, and one has a neonatal form of hypothyroidism. Myxedemia, this is going to be a little bit more common, especially in the United States. So this is from somebody who doesn't have enough thyroid hormone. So it is hypothyroidism, but in adults. And usually because thyroid hormone makes you warm, if you're not secreting enough thyroid hormone, you're going to be cold. So you're usually very sensitive to cold, and your metabolic needs or your metabolic activity is going to be reduced, so you're going to feel sluggish. And then we'll also see goiters. Goiters are referred to broadly as any type of thyroid enlargement, but we're going to talk about something that's more specific. So, in the thyroid gland being a disorder, the thyroid gland will enlarge because it doesn't get enough iodide. And in that case, it's going to still keep making that thyroglobulin molecule, but it can never convert it to T3 and T4 because there's no iodide to attach it to. So the thyroglobulin will begin to build up, and as it builds up in the thyroid gland, the thyroid's going to get larger. And this is actually one of the reasons why we have iodized salt in the United States, is to prevent the formation of goiters. So this is just a picture of a normal thyroid gland versus an enlarged thyroid gland causing that goiter. Graves' disease is going to be the opposite of myxedemia. This is an autoimmune disorder or condition, so that basically what happens is your body forms antibodies against the thyroid stimulating hormone receptors on the thyroid. And the antibodies basically act like thyroid stimulating hormone that's released from the anterior pituitary. And it ends up stimulating the thyroid to make T3 and T4, even though there are normal levels of those hormones. And so the symptoms of this are going to be opposite of hypothyroidism. These individuals will have a really big appetite, but they're still going to lose weight. All of their metabolism is going to be increased. And it does cause this really odd symptom that's called exo-opto-thalmos. Exo means out, opto is eyes, so it literally means eyes out. And these individuals will have these bulging eyes. Treatment can make this go away, though. So circling back to those parafollicular cells that secrete calcitonin, what's going to stimulate these parafollicular cells to release this hormone calcitonin is going to be high levels of calcium. And those high levels of calcium are going to act on osteoblasts within the bone. So if we call from the skeletal system, we learned about osteoblasts and how they build bone by removing calcium and other minerals from the blood and depositing it into the bone. Well, what stimulates these cells to do that is calcitonin. And this is really important in children, but there is a little less of an effect in adults. And then the opposite or antagonist of this hormone is going to be called the parathyroid hormone, which we'll talk about. So here we have a picture of those, the thyroid gland, and we have those follicles. You can see that simple cuboidal epithelium of the follicular cells. And then if you look here, we have these other cells that are more few and far between. We have those parafollicular cells that are going to secrete the calcitonin. If we take a look at the posterior portion of the thyroid gland, or the back part of the thyroid, that's where we're going to find the parathyroid hormone, the parathyroid glands. They produce parathyroid hormone, and that's going to have the opposite effect of our calcitonin. So if we end up having parathyroid hormone being stimulated and released, that is going to have an action on our osteoclasts. In the skeletal unit, we learn that osteoclasts break bone down. So whenever we have low levels of calcium in the blood, the osteoclasts will be stimulated by parathyroid hormone to break down the bone to release that calcium into the blood. And when it breaks down that bone, phosphate will get released into the bloodstream as well. So that way that calcium and the phosphate can be used by cells. I want to note that calcium and phosphate, once it's in the blood, are going to be inversely related. So whatever you do to calcium, the opposite's going to happen to phosphate. So parathyroid hormone will have an effect on the kidneys. And that will tell the kidneys to conserve calcium and not to excrete it in the urine. So since we're going to save calcium, that means the kidneys will excrete phosphate. And that is going to cause the blood calcium levels to rise and the phosphate levels to decrease. And then we're also going to have the parathyroid hormone act on these intestines. And that's going to have those small intestines absorb more calcium, which will also increase the blood calcium levels. So here is another image of where those parathyroid hormones or glands are located. But this is never really how it looks. It's always really pretty in these diagrams, but a lot of the times these cells aren't even in a cluster. Sometimes they're even spread out, and it's really a non-discrete organ. But it will be located on the posterior part of the wings or lobes of the thyroid gland. And so if we look at the histology and underneath a microscope of the parathyroid hormone, we're going to look and we're going to see a majority of these cells look the same. And these cells are called chief cells. You can see that they are cuboidal in shape and there are many layers. So this is a stratified cuboidal epithelium. And then we have these adipocytes, which are fat cells. And then these areas here, what you can see are blood vessels with red blood cells inside of them. And so these chief cells are going to produce parathyroid hormone. And then take a note of these other cells here. They are very few and far between, but they are definitely much larger than those chief cells. So what's going to stimulate the parathyroid gland to release parathyroid hormone is going to be low blood calcium levels. That low blood calcium level is going to stimulate the parathyroid glands to release parathyroid hormones, and they will have an act on the kidneys to have the kidneys reabsorb calcium from the urine and excrete phosphates, and this will actually activate vitamin D. Vitamin D causes an increase in absorption of calcium from the diet, so that will have an effect in the small intestines. And then in the bone, parathyroid hormone will stimulate those osteoclasts, where bone resorption will happen, and that will release calcium into the blood. So normal blood calcium levels is about 9 to 11 milligrams per deciliter. And if that blood calcium level is too low, that is going to be detected by that parathyroid gland. And then the parathyroid gland will in turn produce parathyroid hormone. The parathyroid hormone will act on those osteoclasts to break bone down, releasing the calcium and that phosphate. And releasing that calcium will cause those levels to rise, and that will return our blood calcium levels to homeostasis. If the blood calcium levels are too high, well, that's going to be detected by the thyroid gland, and we're going to see the opposite effect. The thyroid gland will produce a hormone called calcitonin, which will have an effect on the osteoblasts. Those osteoblasts will take calcium from the blood and have it absorbed into bones. That will decrease the blood calcium levels, returning our blood calcium back to normal or homeostasis. So there are some disorders when it comes to the parathyroid hormone. If we are secreting too little of the parathyroid hormone, it will be a hypoparathyroidism. And if we are secreting too much, it will be a hyperparathyroidism. So hypoparathyroidism is going to be mostly due to the removal of the thyroid glands, and that usually causes a rapid decline in our calcium levels and produces something called tetany. And tetany can be very dangerous, so we have to supplement with calcium. Hyperparathyroidism is usually going to be caused by a parathyroid tumor, and this is going to result in brittle bones, and those bones will be soft because the calcium will be removed from the bones. So we'll see an increase in blood calcium levels. We'll also see kidney stones because calcium is going to start to build up in the kidneys. So when we look at the adrenal glands looks like here. We have one atop each kidney. And the adrenal glands have two different layers. They will have an outer layer that's called the adrenal cortex, and then an inner layer that's called the adrenal medulla. The inner adrenal medulla is made up of a neural tissue, while the outer cortex will have three layers. It will have one layer that will secrete mineralocorticoids, an area that secretes glucocorticoids, and then an area that secretes sex hormones. So the adrenal medulla, this is the inner portion, and this is the area that regulates our fight or flight responses. And it gets our bodies ready for an emergency situation. Therefore, we're going to have an increase in heart rate, blood pressure, blood flow, intake of oxygen for immediate use. While the adrenal cortex is going to release our glucocorticoids like cortisol and aldosterone, and that's going to regulate ion levels for quick energy. Here we can see an actual image of a kidney here, and this is the adrenal gland. So I just want to note that it's not actually attached to the kidney. There is this space in between. And so if we were to look at a cross-section of the adrenal, we can see that the adrenal does have a capsule that surrounds it. And then there is an outer layer that is the cortex, and then the inner medulla layer. And if we zoom in microscopically, we can really see how there is a space here. And if we focus just on this adrenal gland, you can see that there's definitely that capsule. And then you can see the outer cortex layer here. And then you can see the adrenal medulla here. And this is zooming in even further. The capsule, once again, is this outermost layer. And you can see a difference in the staining and in the organization of the cells that make up the cortex here versus the medulla here. So looking at the adrenal cortex, over on the right, we can see those layers or zones. The outermost layer is called the zona glomerulosa, and then the middle layer is the zona fasciculata, and then the innermost layer is the zona reticularis. And then on the innermost side, we have that medulla, the adrenal medulla here. So we will start with the adrenal medulla because we've actually already talked about this one. The adrenal medulla is responsible for your sympathetic nervous system with the fight or flight response. In the nervous system, we learned about the autonomic nervous system and how that autonomic nervous system includes the sympathetic and the parasympathetic nervous system. So the sympathetic nervous system is that fight or flight with the epinephrine and norepinephrine, and the parasympathetic is that rest and digest. So the sympathetic nervous system is going to really function to get things ramped up. We also learned about preganglionic fibers and postganglionic fibers that were found in the autonomic nervous system. The adrenal medulla is innervated by the sympathetic postganglionic fibers. So they go into the adrenal medulla, and when they're stimulated, the medulla will release epinephrine and norepinephrine. They'll release a little bit of dopamine as well, but we'll focus on these hormones of epinephrine and norepinephrine together because as a class, they're called catecholamines. So there are many effects of these catecholamines. As a hormone, epinephrine and norepinephrine have many effects, but think about the effects of these to deal with a crisis. So if we have to fight or run, in order to prepare for that, this hormone will increase glycogen breakdown, that glycogen that's stored in the liver. That way there's enough glucose for energy production. And we're going to see this glucose sparing effect. We're going to have gluconeogenesis by the liver. And if we break down that word, gluco means glucose, neo means new, Genesis means to make. So this is making new glucose by the liver, and that's going to also increase our glucose levels. Epinephrine is going to have an effect on the pancreas and the secretion of insulin, and that's going to cause that glucose sparing effect. So muscles will use fatty acids. That way we can save glucose for the brain. And the catecholamines are also going to increase our blood pressure, heart rate, blood flow to the muscles. It's going to restrict blood flow to the gastrointestinal tract, but it's going to increase pulmonary airflow so we can get oxygen to those cells for ATP production, and it's going to overall increase our metabolic rate. So the cortex is going to be the area that surrounds the medulla. And this area will secrete corticosteroid hormones. And there's going to be 3 layers of this glandular tissue. The zona glomerulosa is going to be a very thin outer layer. And this is going to secrete mineral corticoids that will function to regulate the body's electrolyte balance. And then the middle layer is a lot thicker, and that's the zona fasciculata. And that secretes glucocorticoids and a little bit and the androgens. And I do want to note that there's going to be some overlay, like the zona fasciculata is going to do a little bit of sex hormone production, like what happens in the zona reticularis. And the zona reticularis is going to do a little bit of the glucocorticoid production. But these are just the main jobs. So here's a diagram looking at zooming in on the adrenal cortex. This is the more cartoony version, and this is the histology. You can see that capsule in the outermost layer that has these the zona glomerulosa, and then we have this much thicker layer, and then we have the innermost layer, which is the reticularis. And then this inner layer here is the medulla. But you can definitely see 3 distinctive layers. So some hormones that are produced in the adrenal cortex are aldosterone. This is one of those mineral corticoids that are produced in the zona glomerulosa, and this is going to regulate our water and electrolyte balance. So the target of this hormone will be the kidney, and it will have an effect on the kidney to keep sodium. And it's going to also stimulate potassium to be excreted in the urine. So the stimulus to release aldosterone is going to be renin and angiotensin II. And it will be also inhibited by a hormone called atrionatriopeptide that we'll talk about later. So the middle layer of the adrenal cortex is going to respond to ACTH that is released from the anterior pituitary. And in turn, it's going to release glucocorticoids. This is going to regulate the metabolism of glucose and other fuels in the body. They're called glucocorticoids because it affects how the glucose is broken down. So cortisol will stimulate fat and protein catabolism or breakdown. That's not fate, it's supposed to say fat. It's also going to stimulate gluconeogenesis, and it will release fatty acids and glucose into the blood. Cortisol will also help the body adapt to stress, and it will help repair tissues. And these glucocorticoids will have some anti-inflammatory effect And that's good at first, but after long-term exposure to these glucocorticoids, we're going to start to see immune suppression. And if you look at this word, I just want to break this down real quick. Gluconeogenesis. If you look at gluco means glucose, neo means new, and genesis means to make. So this word literally means make me some new glucose. All right, so I want to take a second to bring up this concept in case we've never heard of it before, but it's this concept that whatever sodium does, water does. So if you keep sodium, then you're going to keep water. If you keep water, that's going to increase your blood volume and therefore your blood pressure. If you get rid of sodium, well, then water is going to follow it and you're going to get rid of that water. So if we look at stress, stress will impact the hypothalamus, and it will cause the hypothalamus to release a hormone that stimulates the anterior pituitary. That anterior pituitary will release ACTH, which will have a direct effect on that adrenal cortex. That's going to increase secretion of aldosterone and cortisols, and those aldosterones will go to their targets of the kidneys. Those kidneys will then increase absorption of sodium, therefore increase absorption of water, and increase potassium excretion. So by increasing the sodium, we're going to hold on to water, and then we're going to increase our blood pressure. So if we have an issue where we initially have low sodium, high potassium, and low blood pressure, that problem is going to be corrected through these actions of aldosterone. But if you look at this other side, this heart side, we're going to see an opposite effect. Because if that blood pressure continues to increase, well, that's going to stretch this part of the heart, a chamber in the heart that's called the atrium. And when the atrium stretches, it's going to release atrial natriuretic peptide. And that's going to have an inhibitory effect. So that will go to the adrenal gland and say, hey, I have too much blood. I don't want any more blood. I'm stretching too much. And that will inhibit the production of aldosterone. So that stress, it can be a physical stress, it can be a psychological stress or an environmental. It could be something like surgery, infection, extreme grief. But that stress will impact the hypothalamus, which will then stimulate the pituitary gland, which will then stimulate the adrenal glands to release this cortisol. And then the hypothalamus will respond to the levels of the cortisol by reducing how much CRH it releases. However, with long-term stress, so this is good short-term, but long-term, we're going to start to see that there are immune inhibitions with that long-term cortisol release. So if we dive more into this idea of stress, stress can be any situation that is going to disrupt homeostasis, whether that's physical, like intense exercise or a surgery, or it can be emotional, like depression and anger. You have a way to deal with this stress, and it happens in 3 stages. And the way we adapt to it is called general adaptation syndrome, or GAS. if we are constantly being exposed to stress, this is typically going to involve elevated levels of epinephrine and glucocorticoids, especially that cholesterol. So the first stage is called the alarm reaction. It is your initial response. It is mediated by norepinephrine and stimulated by the sympathetic nervous system. It will also be stimulated by epinephrine that's released from the adrenal medulla. This is going to prepare your body for that fight or flight response. It's going to help raise your blood volume and raise your blood pressure because we're going to have increased aldosterone and angiotensin levels. So aldosterone is going to promote sodium to be retained from the kidneys, which is in turn going to help us or cause us to conserve water. And then angiotensin works on your blood vessels to cause vasoconstriction, or they constrict, and that will raise blood pressure. Stage 2 is called resistance. So by this point, we've burned through the glycogen storage reserves within a few hours. But remember, the brain still wants glucose. It can't use anything else. It wants glucose. So the body is going to start to use alternate fuels for metabolism. And this stage is going to be dominated by cortisol. So the hypothalamus is going to secrete CRH, and that's going to cause the anterior pituitary to secrete ACTH. That will then stimulate the adrenal cortex to secrete cortisol and other glucocorticoids. That's going to promote fat and protein breakdown into fuels, and then those fuels can be used for gluconeogenesis. Cortisol will also have a glucose-sparing effect, so we can save that glucose for the brain. So cortisol will actually begin to inhibit protein synthesis because we need to save that energy for the brain. And if we're going to be breaking down proteins, we shouldn't be making proteins because we're breaking them down so we can use them. And so we don't want to use those amino acids to make new proteins. We want to leave those amino acids as free amino acids so they can be used in gluconeogenesis. If there's excessive cortisol, we're going to start to see a depressed immune system. We're going to see increased susceptibility to infections and ulcers. The tissue of the lymphoid system is going to begin to atrophy or break down. And we're also going to see poor wound healing and increased infection because we're going to start to see antibody levels drop. The next stage is exhaustion, which I'm sure we are all feeling right about now. When stress continues for several months, by that time the fat reserves are gone and homeostasis is overwhelmed. So we're going to start to see a rapid decline of health and death. Proteins have been broken down and muscles are now being broken down into proteins, and so we're going to start to see that muscle wasting. There is a loss of glucose homeostasis because the adrenal cortex stopped producing those glucocorticoids. With the aldosterone, that's going to promote water retention and hypertension because when we retain water, that causes extra pressure or tension within our blood vessels. So sodium's conserved, and then that increases the elimination of potassium and hydrogen. So by eliminating potassium so quickly, we're going to go into hypokalemia, which is low potassium. And by getting rid of the hydrogen ions, that is going to turn our bodies very basic, and they'll go into alkalosis. And that's because there's not enough hydrogen ions in the body, and that can cause death. And the death will typically result from heart or kidney infection, and it's usually an overwhelming infection. So let's look at both long-term stress and short-term stress, because we've all heard that stress can kill. Well, short-term stress involves the sympathetic nervous system. It includes the nerve impulses that are going to come through the pre and post ganglionic neurons that go to the adrenal medulla, and then the adrenal medulla is going to release those catecholamines, and we will have our short-term stress response. This is going to result in increased heart rate and blood pressure, converting glycogen to glucose to raise those blood glucose levels. It's going to dilate your bronchioles so you can have better airflow, and you're going to have an increased alertness. Some stressors are longer, and these hormones we're going to talk about are hormones of the adrenal cortex. So stress will act on the hypothalamus, and the hypothalamus will then release corticotropic releasing hormone, or CRH. That CRH will travel through the blood, through that infundibulum of the pituitary gland to the anterior pituitary. Will act on corticotrophic cells within the anterior pituitary. Those cells will release the ACTH, which will then travel through the blood to the adrenal cortex. The adrenal cortex will then release mineral corticoids, which are mainly aldosterone. And then we're going to release glucocorticoids, which are mainly cortisol. This will allow us to retain sodium, which means we automatically keep water. It increases our blood volume and then blood pressure. The proteins and fats are going to be converted to glucose that can be used for energy, and this will increase our blood glucose levels, but it's also going to suppress our immune system. So the two adaptations for stress are short-term and long-term. They're both going to involve the adrenal gland. Short-term stress is going to be the adrenal medulla, and long-term stress is going to be the adrenal cortex. Within the adrenal cortex, in the zona fasciculata and the zona reticularis, we have the sex steroid hormones. And we're going to talk about these a lot in the reproductive unit, so I'm just going to briefly introduce them now. But androgens are more male hormones, and estradiol is a female hormone. So androgens will set libido, and it plays a large role in the prenatal male development. Estradiols is going to be secreted in small quantities. So it's going to be mostly secreted in the reproductive system, but it will have a little bit in the adrenal cortex, and it's going to be important after menopause for sustaining bone mass in adults. So if there is a disorder of the adrenal cortex, such as Addison's disease, you're going to have hyposecretion of all of the adrenal cortex hormones. That means you're not secreting enough hormone. And since one of the hormones you're not making enough of is aldosterone, you're not making the cortisol, that means that you're going to have low blood sugar, which is hypoglycemia. A result that we're going to see from this is muscle loss, weight loss, fatigue, and it can be life-threatening. Low blood sugar and high potassium levels, low sodium levels can result in life-threatening effects called dystonia. And some interesting side effect or appearance of Addison's disease is this nice tan all the time. There's this nice bronze skin tone. And so Kennedy actually had Addison's disease and it was hidden from the public because they were afraid no one would vote for somebody who could die if they got stressed out. So Kennedy is a good example of somebody with Addison's disease. And the cause of the bronze skin is unknown. Well, fun fact. The opposite of Addison's disease is going to be too much cortisol, or there's being too much ACTH being secreted from the anterior pituitary gland. So this is called Cushing syndrome. And what we're going to see is that there is a hypersecretion. So there's too much hormone. And that's going to give a presentation of a moon or a round face. There is the buffalo hump that's on the back. We're going to also see them present with high blood pressure as hypertension and high blood sugar, which is hyperglycemia. And they're going to have rapid bone and muscle loss. And so if you've ever been walking around the mall and you see somebody with kind of that pop belly and they have a real round face and red cheeks, they may have Cushing syndrome. And they will also have some stretch marks too. A pot belly with stretch marks and then the round face with the rosy cheeks. And it's actually called Cushing syndrome because the first case was described in 1912 by Dr. Harvey Cushing. So we'll talk about the pancreas next. The pancreas has both exocrine and endocrine glands. And so if you need some review on that, you can click this link here or copy that down and go to that website, but it's a really good explanation of endocrine versus exocrine glands. But we're going to focus on the endocrine or the ductless portion of the pancreas. So the endocrine part of the pancreas is made up of these little groups of cells that are called islets of Langerhans. And they're given that name because they look like little tiny islands. Well, the islets of Langerhans are going to produce hormones, insulin, and glucagon. So in the pancreas, within these islets, we have specific cells that are called beta cells. Those beta cells will secrete insulin. And then that insulin will have effects on the liver. And it will tell that liver, hey, we have too much sugar in the blood. I need you to take some of the sugar and I need you to make glycogen out of it. And so the liver will remove that glucose out of the blood and form this molecule of glycogen and store the sugar for later use. And then the second target of glycogen is going to be on the body cells. And the glycogen is going to tell the body cells, hey, I got too much blood sugar. I need you to take up some of this blood glucose. And then those cells can take up that blood glucose and they can use it in cellular respiration to make ATP energy. Well, if we happen to be in a fasted state, that is going to be detected by the pancreas and stimulate alpha cells in those islets of Langerhans to secrete a hormone called glucagon. Glucagon is the fasting hormone. That is going to raise your blood glucose levels because it's going to travel to the liver as a target and it's going to tell the liver, hey, remember all that glucose you stored as glycogen? We need that now. And so the liver is going to start breaking down that glycogen, releasing the glucose into the blood and raising the blood sugar levels. is a picture of the pancreas. It sits just atop a loop in the intestines and just underneath your stomach. Underneath, you can see the microscope. This image here, you can see these darker cells. These cells are those exocrine cells that are going to release sodium bicarbonate for the digestive system. But if you look at these lighter pink cells here, this little cluster of cells, this is something that's called an islet. And if you look very closely at that islet, there are two types of cells. So it's shown a little better here. There are actually three. But we're going to first talk about the alpha and the beta cells. This is what a human pancreas looks like. You can see the head, and then you can see the mid-body and the tail of the pancreas there. This actually wraps around the portal vein. If we look at the pancreas underneath the microscope, you can see that a majority of the pancreas is going to be exocrine. And just these little tiny blue dots here are those islets of Langerhans, and that is the endocrine pancreas. So we're going to zoom into those little islets. And so here is a higher magnification of those islets, and you can start to see that it tends to be this cluster of lighter staining cells. And it does have a very rich blood supply. So here I have a blood vessel, blood, 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 blood. And it has a rich blood supply with all of these capillaries that you can see embedded through it. Because if this is going to be endocrine, we need to be able to move the hormones into the blood. You can see the capillaries highlighted here. So the pancreatic islets will contain alpha cells. So when we are in a fasted state between meals or when we just wake up, those alpha cells will respond to blood glucose levels dropping. The alpha cells will release glucagon that has a target of the liver. So the liver will be stimulated to perform gluconeogenesis. It's also going to do glycogenolysis, and it's going to release glucose into the blood. So glyco is that glycogen, geno, and lysis means to break. So this is breaking down that glycogen molecule. And that is all going to increase blood glucose levels. The glucagon will also have a target of the adipose tissue where it's going to stimulate the breakdown of fat. And that's going to release free fatty acids to be used for energy. Glucagon is also going to be released when amino acid levels in the blood rises. So that will promote amino acid absorption by the cells. So that way the cells can use the amino acids and raw materials for gluconeogenesis, and we can save any glucose that's available for the brain. When we are in a fed state after a meal, we're going to see an increase in blood glucose levels and amino acid blood levels. And this is going to be detected by the pancreatic beta cells. Those will then release insulin. Insulin will have two effects. It will stimulate body cells to absorb those glucose and amino acid nutrients to either store them or to use them in metabolism. By body cells absorbing the glucose, that will lower the blood glucose levels. It's also going to promote synthesis of fat and proteins and glycogen because the body's going to want to store and save everything that you just gave it. And then because we have glucose, that is the body's preferred source of energy, we're going to start to suppress the use of already stored fuels. Some tissues can absorb glucose without insulin, but every other tissue is going to require insulin. So the brain, the liver, kidneys, and red blood cells, that's supposed to be a C, and red blood cells will actually all absorb glucose without insulin, but the tissues will require insulin. So I love this diagram. Feel free to take a screenshot of it because it is a great flow chart of what happens when we have fed and fasted states. So when it comes to blood glucose, there are two different stimuli. We can have the first stimulus if we have a rise in those blood glucose levels, and you can see that that's going to be detected by the beta cells in the pancreas, and they will release insulin into the blood. Insulin will have two targets. One will be in the body cells to take up that glucose and use it or store it, and the other effect will be on the liver. The liver will take up that glucose and store it as glycogen. And both of those together are going to cause the blood glucose levels to decline, restoring homeostasis. If we happen to be in a fasted state and those blood glucose levels fall, those alpha cells in the pancreas will release the glucagon, and that glucagon will have a target of the liver, and it'll tell the liver, hey, all that glycogen you made for us and you're storing, time to start to break it down. I need it. And so the liver will break down that glycogen and it will restore homeostasis. And then there is that third cell that we mentioned, or I didn't mention it, but we looked at it on the image. Those are delta cells. And delta cells will release a hormone called somatostatin. And somatostatin will be released at the same time as insulin. And what somatostatin does is it inhibits further release of insulin and glucagon and gastric hormones. So it will slow down gastric emptying. We will also see an effect on hyperglycemic hormones that will raise blood glucose concentrations. So this is going to include hormones from other glands like growth hormone, epinephrine, cortisol, and glucagon. And then you have the hypoglycemic hormones. Those are the hormones that are going to lower blood glucose levels. And the main one that is hypoglycemic is insulin. All the other hormones will increase or raise your blood glucose levels. So some diseases of the pancreas includes diabetes. Type 1 diabetes used to be called juvenile diabetes, and sometimes it's referred to as insulin-dependent diabetes, but this only makes up about 5 to 10% of cases in the United States. The treatment includes insulin, so those can be insulin injections, pumps, or an insulin inhaler. These people have to monitor their blood glucose levels and eat a very controlled diet. There is also a heredity component to this. So susceptible individuals, if they are infected with certain viruses like rubella or cytomegalovirus, they will form autoantibodies that will actually attack and destroy these pancreatic beta cells. And once those cells are destroyed, they're gone. And so these people can then no longer produce insulin. So people who have type 1 diabetes, they have either hyposecretion of insulin or they cannot make that insulin. So since they can't make insulin, they can't do things like regulate blood glucose, fat and protein metabolism very well. And so we're going to see a disruption in that carbohydrate, fat, and protein metabolism. All the symptoms start with the letter P and the prefix poly. So we're going to see polyuria, which is urinating too much, polydipsia, which is they're very thirsty or drinking a lot, or polyphagia, where they're eating a lot. And so under the labs, we're going to see that these individuals have very high blood sugar levels, which is hyperglycemia, and that extra glucose is going to spill into the urine in glycouria. And if it's very unregulated, they're going to produce substances that are called ketones. And ketones are very dangerous if you see them in the urine. Type 2 diabetes is caused by excessively poor diet choices and lack of exercises. It basically occurs by throwing glucose at cells for years and years and years, and then they just stop responding to insulin. So it's known as insulin resistance because the target cells are no longer listening to insulin and taking in that glucose like they're supposed to. In the United States, this makes up 90 to 95% of diabetes, and the biggest risk factor is obesity. But as we age, that does increase our risk. There is a small heredity component, and ethnicity can have an impact. This can typically be treated with diet and exercise. But if weight loss program treatments and exercises does not work, then there can be medication used. That is an oral medication, and if that's still not enough, then insulin can be used. So cells have to have glucose for energy. It's an input for cellular respiration to make adenosine triphosphate, or ATP, energy. So if they can't get glucose, they're going to break down fats and proteins. And when they break down fats and proteins, they make a byproduct that's called a ketone. And what ketones are they are very strong acids. There will be ketones in the blood, and those ketones can spill into the urine, which we call ketonuria. And because they're acids, this actually causes the person to become too acidic, which is called ketoacidosis. And ketoacidosis can be very life-threatening. This can lead to electrolyte abnormalities, neurological issues, and seizures, and if left untreated, it can lead to death. If there is chronic pathology, that can lead to neurological issues and cardiovascular damage. There can be arterial damage in the retina, which can cause blindness, and there can be damage in the kidneys that can cause kidney failure, and that's in it's supposed to be type 1. And there can be atherosclerosis that leads to heart failure. That's going to be common in type 2. Diabetic neuropathy is basically nerve damage that's caused from poor blood flow, and that can lead to poor wound healing and loss of sensation in the area. A lot of times in type 2 diabetes, that's in the feet, and they end up having to have amputation. So we're going to finish with the minor endocrine glands. And one of the glands we looked at last week was the pineal gland. This is a tiny cone-shaped gland that's near the cerebellum. It is part of the epithalamus, and it's attached to the roof of that third ventricle. The main secretion of the pineal gland is melatonin, and that functions in your body's circadian rhythm and your sleep-wake cycles. This gland shrinks rapidly after age 7, and it's thought to be involved in the timing of puberty, and it may be involved in some mood disorders. So melatonin's main function, though, is going to be the rise and fall during the day that causes those sleep-wake cycles. If there is no regular sleep-wake cycle, we can develop a disorder that's called seasonal affective disorder. And this doesn't occur much here in Arizona, but in a lot of the northern climates like Alaska, where there's a lot of darkness, these people can experience a lot of depression, irritability, sleepiness, and the way it can be treated is actually just phototherapy. 2 to 3 hours of exposure to bright light every day, and that will reduce those melatonin levels and then reduce the symptoms. In the pineal gland, you're going to see microscopically there is this structure here, and that is actually called brain sand. Brain sand is little carbon deposits that accumulate in the pineal gland as you age. So the older you are, the more brain sand you'll see in the pineal gland. Right atop of the heart sits a gland called the thymus, and the thymus matures specific white blood cells that are called T cells. It is located in the sternum mammary, and it's really large in children, and it shrinks after the age of 60, so it will get smaller. But it plays a role in 3 body systems. It's going to have a role in the endocrine system, the lymphatic system, and the immune system. So this gland is going to produce a few different hormones, but specifically it's going to produce thymosin, which is involved in the development of the immune system, which is why it starts to shrink as you get older because you've already developed your immune system. So here is just an image of the thymus. You can see in children it is much, much larger than in an adult. And then as we get older, it will continue to shrink. When we look at the thymus under the microscope, it's going to look like many other glands where it's going to be broken into these lobes. And the lobes are separated by these walls that are called septa. And you can also see that the thymus has a cortex, that's an outer layer, and then it has an inner layer, that is the medulla. So the gonads we are going to go into when we talk about the reproductive system, but to just briefly go over it, the gonads are reproductive organs, but they also have a function in the endocrine system. But these produce sex cells and secrete sex hormones. So the ovaries will produce eggs, while the testes will produce sperm. And so there are 2 hormones that are going to be produced by the ovaries, and that's estrogen and progesterone. Estrogen is going to help with the maturation of reproductive organs and the development of secondary female characteristics like mammary glands and soft skin and wider hips, all the things that you think of when you think of feminine. Or with progesterone, progesterone is a hormone that will also work to develop secondary female sex characteristics like breast development, but it's also going to function in control of the menstrual cycle. Androgens are produced in the testes, and an example of estrogen of an androgen, and what's said to be the most important one, is testosterone. Testosterone is going to help mature reproductive organs and secondary male characteristics, such as denser bones and stronger muscles and facial hair. It is also going to function in the production of sperm. So here is a picture showing the locations of the ovaries in a, there it is located in the body. So hormones of the ovaries are going to include the estrogen, which will stimulate the development of the secondary female characteristics and maturation of female reproductive hormones, while the progesterone will act with estrogen to bring out the menstrual cycle. Progesterone is also going to help with the implantation of an embryo in the uterus and help prepare the breast for lactation. Estrogen and progesterone will promote breast development and regulate the menstrual cycle when they work together. Hormones of the testes are going to be several of those androgens, and these are going to produce those secondary male characteristics that we see, such as the deeper voice, the bigger muscles, and those denser bones. So some other organs and tissues that have endocrine functions are things like the liver. The liver actually produces at least 5 different hormones. It will secrete a hormone or prohormone called angiotensin. And that angiotensin is a precursor of angiotensin 2, which will regulate blood pressure. It also secretes erythropoietin. Erythropoietin will have an effect in the red marrow of the bone and stimulate red blood cell production. Your kidneys will also produce 3 different hormones. They will secrete a hormone called renin that will convert that angiotensin that's produced by the liver to angiotensin 1, and then the angiotensin 2 is created by converting enzymes within the lungs. And that angiotensin 2 in the lungs will then construct blood vessels and raise blood pressure. The kidneys are also going to produce the rest of the erythropoietin to stimulate bone marrow to produce those red blood cells. The heart also has some endocrine function. For example, in the atria, the muscle that makes up that atria will secrete 2 natriuretic peptides in response to increases in blood pressure. So these will decrease blood volume and then therefore blood pressure by increasing sodium output in the kidneys. So water will follow and be excreted out. This will oppose the action of angiotensin 2 and lower the blood pressure. The stomach and the small intestines also have specialized cells called enteroendocrine cells. And these cells secrete at least 10 different hormones, and that will coordinate digestion, the motility of the digestive system, and glandular secretion, like in the stomach, those gastric cells that have to release all those gastric juices. Your adipose tissue also has an endocrine function because it secretes a hormone called leptin that's going to slow your appetite. So if that adipose starts to get broken down, it will stop secreting that leptin and that will increase your appetite. The placenta can also act as an endocrine organ because it will secrete estrogen, progesterone, and other hormones to regulate the pregnancy. And it will stimulate the development of the fetus and mammary glands. So we're going to end the chapter by briefly mentioning paracrine signaling again, like we talked about in the very first lesson. So remember that these paracrines are similar to hormones, but they're going to act very locally. So some examples of chemicals or these hormones that act locally are histamine. Histamine will be secreted by mast cells that are in the local connective tissue, and that histamine will cause relaxation of blood vessels. Another example is from the endothelium cells that make up those blood vessels. They will release nitric oxide that will cause those blood vessels to dilate, or vasodilation. And then we also have the catecholamines that will be secreted from the adrenal medulla to the adrenal cortex. And a single chemical can act as a hormone, it can act as paracrine, or even a neurotransmitter in different locations. like epinephrine and norepinephrine. Eicosanoids are an important type of paracrine, and they are derived from a fatty acid that's called arachidonic acid. Well, arachidonic acid comes from cellular membranes, and you have an enzyme that's called lipooxygenase, and that will take arachidonic acid and it will convert it to a leukotriene. And leukotrienes actually are what causes allergic reactions and inflammatory reactions. So cyclooxygenase is also abbreviated as COX, C-O-X. That's going to convert arachidonic acid into 3 other types of eicosanoids. There is prostacyclin, which will inhibit blood clotting and cause vasoconstriction, thromboxane, which will be produced by blood platelets after there's been an injury, and that will actually override prostaglandin to stimulate vasoconstriction and blood clotting. And then there are prostaglandins, and there are 2 main types. There is PGE, which will relax smooth muscle in the bladder, intestines, bronchioles, and it will stimulate contraction of the blood vessels. And then there is PGF, which will have the opposite effect. So the cell membrane, if you look at this cell membrane up here, this is where the arachidonic acid comes from. And then leucooxygenase will turn into leukotrienes. And cyclooxygenase, or COX, turns it into protocyclines and prostaglandins. And so we have medicines like aspirin and Advil and ibuprofen that are anti-inflammatories. And they actually work by blocking the cyclooxygenase. And that's great because they're going to block inflammation. But they're also going to block the actions of blood clotting. And when these drugs are taken chronically, we're going to start to see blood clotting issues. So we have cortisol and corticosteroid, which are steroids. So these will work by inhibiting inflammation by blocking the release of arachidonic acid from that plasma membrane. So we have no arachidonic acid. So the process cannot continue. And that will inhibit the synthesis of these eicosanoids. But one disadvantage is this is going to then produce symptoms of Cushing's disease. And then we have the things like aspirin, ibuprofen, that are the non-steroidal anti-inflammatories, and those work by inhibiting COX. All right, we made it. So now you guys can go back and you can review these lessons and you can prepare for your exam. I look forward to seeing you for our next lab. We're going to finish up the endocrine system and look at these microscopic structures. Our next unit will be the cardiovascular system. See you guys later. Have a great night.